Thank you. Good morning, everyone. I've been asked to talk this morning about nasopharyngeal carcinoma, which is a cancer that we see a lot of in Hong Kong. In this lecture, we're going to have a look at the background. Come in. And then we'll go on to staging, a quick look at structured reporting, and then how we do primary tumour staging, nodal staging. And then we'll just finish up with an area that we're using MRI more often for, which is early detection of cancer. So we'll start with the background. Come in. Okay, so it's endemic in certain areas of the world, particularly in southern China. A lot of our Chinese patients have NPC. Where we are, most of these are an undifferentiated carcinoma. I think in the West you may see more squamous cells and differentiated cancers. The peak where we are is males, sort of middle-aged males, so usually the working man who needs to support his family. This cancer that we see is very sensitive to radiotherapy. In stage 1, the overall survival is greater than 90%. For the higher stages, of course, that drops. And it's a very topical cancer at the moment because it has strong genetic links. There is a strong family history and a strong link to viruses, the Epstein Barr virus, and there are also environmental factors. So if we go on to staging, and if I may, I just show you this is my structured report. Now we all have different ways of reporting. For head and neck cancer, I quite like to use staging, and then I will add extra text to that to elaborate on the findings. And this way you make sure that you've checked everything. I think you probably will have this to download if you want to see it. So what I'm going to do in the lecture is I'm going to go through the primary tumour staging and then also the nodal staging. I'm just focusing on the head and neck today. We won't be looking at the body, but always when you're looking at the head and neck, you need to look for distant mets in the head and neck. They're not very common at diagnosis. And also second primary tumours, again, not so common in nasopharyngeal cancer. And then I usually go on to look at other findings like middle ear effusions, and always end up with a conclusion which includes the staging. So what I'm going to do now is go through the T staging and then the N staging for nasopharyngeal cancer. So let's start with the primary tumour staging. So the latest edition is the 8th edition. This has just come out. And so T1 is superficial tumour. So it's tumour in the nasopharynx or tumour that spreads superficially into the nasal cavity or down to the oropharynx. Stage 2 is when it starts to go deeply into the parapharynx, and in the new staging system, this now T2 includes the medial and lateral pterygoid muscles. Previously that was T4, and it also includes going retropharyngeal backwards into the prevertebral muscles. T3 is the skull base, and that includes the pterygoid bones, and if it's very extensive, it may include the upper cervical vertebrae, and of course the paranasal sinuses. And then once it gets even larger and it's gone through the skull base, you involve the cranium and cranial nerves, the orbit, the hypopharynx. The infratemporal fossa we'll look at, the definition of that has recently changed, and also now the parotid gland is in the new staging system. So we're going to go through each of those and have a look at some examples. So let's start with T1. So tumour that's confined to the nasopharynx is T1, as you can see here. It's often homogeneous tumour, but it can actually have low and high enhancing areas in it. There are many different walls. There's a roof, there's a lateral wall, there's the pharyngeal recess, the posterior wall, and the inferior wall. But it doesn't make any difference to staging how many walls, and it also makes no difference to staging the size. But if you're going to try and indicate the size, try and use 2 dimensions, because you can't really indicate the size on just 1 dimension. The next one will be nasal cavity, a common site. We usually call it when it's gone past this line that goes through the anterior aspect of the pterygoid bones. Minor is actually very common. More major is not so common. Check the nasal septum, particularly on the coronal, because it can creep round the nasal septum. And sometimes it doesn't go directly, it goes up into the skull base and then back. So you've got to check carefully to see how it gets in. And then the oropharynx. The main thing to remember is that this is a tumour that likes to go up and eat the bone. It's not a tumour that likes to go down. So if you see tumour in the oropharynx, check the skull base. It's likely to be involved, and the parapharynx is likely to be involved. What's the cutoff? I think using the palate is extremely difficult, so we tend to use the C1-2 junction. So I look at the C1-2 junction, and anything below that we would call oropharynx. What about when it's spread outside? Well, you just need to know the margins of the nasopharynx. So this is the fascia coming around here. And inside we've got the levator palatini muscle. We've got the swelling of the cartilaginous tube, the torus tubarius. Anterior is the eustachian tube orifice. And then everything else is outside. So we've got the tensor palatini muscle outside, the medial pterygoid muscle, the parapharyngeal fat space, and the lateral pterygoid muscle out here. And then at the back, we've got the longus and rectus muscles. So once it's gone past this line, it's spread outside. Why is that important? Well, if you have a look at this tumour, it's still inside, and it's bulging into the fat space, but it's not invading it. That's T1. This one here has actually gone through the muscle, and you can see it involving tensor palatini and out into the medial pterygoid and fat space. In some institutions, once it's T2, they may add chemotherapy. So that's where it may make a bit of a difference. Also, if you look at the T2, they're very useful. The fascia is very dark. So here you can see the difference between the primary tumour and the nodes. And equally here, you can see the dark line, but it's partially gone here. So often look at the T2 as well to see whether it's spread outside. When it has spread outside and it's more obvious, then of course it goes into the parapharyngeal region, it goes into the muscles, it goes into the carotid space. It can then compress the eustachian tube, which is why they often develop deafness. And also it can go sometimes not sideways. The only way it goes is back, and it can be very bulky going into the retropharyngeal region here. This again may be an indication for chemotherapy, and it also often there's an increased risk of distant mets, particularly with this pattern because it may invade the lymphatics and the venous system. T3, this is a tumour that likes to go up, and it likes to eat the skull base. It may go nowhere else except up into the skull base. So it may be the only site of invasion. Again, this is now an indication for chemotherapy as well as radiotherapy. This is really for if there are any trainees, to remind you of a checklist. There are about 6 bones plus that you need to look at, 3 foramina, 3 canals, and a fossa and a couple of fissures. So just to remind for the trainees, I always start with the axial T1 at this level here because you can see 5 bones on this. So here are the 5 bones. They're white because they've got fatty bone marrow. So look for the clivus, look for the pterygoid bones, and look for the petrous apices. So always start at that level. And then if you look at the other one, you can see straight away you've got the right pterygoid and the right petrous apex, but it's involving the clivus, the left petrous apex, and the left pterygoid. So a good place to start. Then go to the coronal, and you can have a look at the floor of the sphenoid sinus and go back to the rest of the body of the sphenoid. After that, if it's very extensive, it might go out to the sphenoid ring. It can go down to the occipital condyle and into the cervical spine. But this is really the one to check. The problem with MR, though, is it's very sensitive. Often the tumour will just nibble away at the medial border of the pterygoid here. And as a result, I think with MR, we've ended up upstaging a lot of these tumours to T3, when in the past on CT they would have actually been a T1 or a T2. What about the foramina? So just a revision, where are the foramina? So we start at the front with rotundum, ovale, lacerum, so front to back. So if we start at the front here, we can see the foramen rotundum, which has got the V2 nerve inside. So this is sort of at the level of the orbital fissures, where you're just at the back of the orbit. Go back until you hit the cavernous sinus here. You can see the bone. There's a bone on each side, and the gap in between is where the V3 nerve goes. So this is foramen ovale. And then go right to the back, and at that level there you've got lacerum. Where do you find lacerum? Look for the horizontal portion of the internal carotid artery. There's cartilage there, and the tumour likes to eat the cartilage around the edge, and it may go up, and from there it can wrap around the carotid artery and go into the back of the cavernous sinus. So this is a very common site for invasion. So what does it look like? Well, here's a case of nasopharyngeal cancer, and as you can see, it's gone into foramen rotundum, which is expanded here. It's also on this one, there it's involving foramen ovale, and it's gone up into the cavernous sinus and involving the sphenoid-body. And this one here, you can see there is the horizontal portion of the artery. It's around foramen lacerum and again up into the cavernous sinus. If we go back though onto this anterior view, you can also see the Vidian canal. And on here you can see it's invaded. So the Vidian canal is very nice then to check on the coronal. After that you can go to the axial, so 3 canals. We've looked at 3 foramina, now we're looking at 3 canals. The first one, as I said, is the Vidian canal. So it goes anteriorly from the pterygoid palatine fossa backwards, here's the Vidian canal, to the foramen lacerum. The pterygoid palatine canal is just in front of the pterygoid base, and it can go all the way down where the palatine nerves are, all the way down to the palate. And then you've got the hypoglossal nerve canal here, which you can see is in between the bones here. And often when there's retropharyngeal tumour, it will go in here. Be careful because there's a venous plexus there that can enhance. The tumour doesn't tend to enhance as much as the venous plexus. So we've got 3 foraminae, 3 canals. Then we come on to the pterygoid palatine fossa, which is the danger zone. So here it is. And it's the danger zone because it links to many areas in the face and in the brain and skull base. It goes up to the eye through the inferior orbital fissure. It goes to the brain through foramen rotundum. As we've just seen, it goes back along the Vidian canal to the internal carotid artery in foramen lacerum. It can go medially, this is the other way, into the nose through the sphenopalatine foramen, down the pterygoid palatine canal to the mouth, and out the pterygomaxillary fissure to the infratemporal fossa. So you have to beam into this area because it's going to connect to the brain, the eye, the artery, the mouth, inferior temporal fossa and the nose. Just to show you, here is the pterygoid palatine fossa. If you want to find it, look for the fissure, follow it until you get medially, and then you've got the pterygoid palatine fossa. This is it going outwards along the infratemporal fossa, along the fissure to the infratemporal fossa, back again along the Vidian canal to the foramen lacerum. On the next one, we can see it going, this is bilaterally, and this time it's going back to the foramen rotundum, to the brain. And this one here is the coronal, best seen on the coronal section. Whenever you see something in the pterygoid palatine fossa, always look at the coronal because it can go up the inferior orbital fissure to the orbit. It can go medially to the nasal cavity and down to the mouth. So that's a very important check area to look for in the skull base. So hopefully there are 6+ bones, 3 foramina, 3 canals, a fossa and fissures. The paranasal sinuses, well, obviously the nasopharynx is just below the sphenoid sinus, so the sphenoid sinus is a very common site to have invasion. Ethmoids not so common. They are usually via the sphenoid sinus forwards or sometimes via the nasal cavity. And it's important to look there because it may have an influence on the optic nerve. And then for the maxillary sinus, it usually goes in through the back, and it's really an extensive marker of invasion. The nervous system, it can involve cavernous sinus, as you can see here, and the dura of the middle cranial fossa and the posterior cranial fossa, and the cranial nerves. You can see here this is the V3 nerve being involved, and you can see that there is denervation here in the muscles, the lateral pterygoid and the masticasus space. And this one again is involving the V2 nerve. And I think the next one we often see would be the 12th nerve. The T4, this is the orbit. Whenever you see a mass at the back of the orbit, particularly in a Chinese patient, don't forget to look lower. It may be nasopharyngeal cancer that's coming up. The parotid also often affects the deep lobe, hyperpharynx very rare. The infratemporal fossa, in the latest edition, you look at the lateral pterygoid muscle, and anterior is the infratemporal fossa. And so this here is invasion. Now this is the definition that most of us have been using for the last 20 years. In the 7th edition, anything in the medial or lateral pterygoid was called infratemporal fossa. That has now changed. So infratemporal fossa, anterolateral to the lateral pterygoid muscle. So just to quickly go through, we've looked at T1, superficial spread, nasopharynx, nasal cavity and oropharynx, T2, parapharynx and the muscles, medial and lateral pterygoid and prevertebral. T3 was the skull base and the cervical vertebrae and the sinuses. and T4 is when it's going up into the cranium, orbit, hypopharynx, and infratemporal fossa and parotid. So that's probably the more complicated. Much more simple is the nodal staging. So nodal metastases, they're very common. About 75% may present with nodal metastases because the nasopharynx is a silent area, often causes no symptoms until late. So it may be the first manifestation of disease. It's not related to the size of the primary tumour. You can have a tiny tumour and huge nodes, or you can have a huge tumour going into the skull base and no nodes. There's a tendency for bilateral neck spread, and there's usually orderly spread down the neck, and skip metastases are rare. So this is usually the root. Retropharyngeal is often the first echelon. Sometimes it bypasses those, probably going down that prevertebral region where there are lymphatics to the upper internal jugular chain. From there it goes down the internal jugular chain or down the posterior triangle to the supraclavicular fossa. Spread to the parotid and the submandibular is much rarer, and it tends to be seen when there's very bulky disease here in the upper neck. What does it look like? This is retropharyngeal nodes. You can see here they're medial to the carotid artery. We take 5 millimeters as the short axis. There are people who take 6 and 8, but we've stuck to 5 millimeters for many years. As I said, it's the first echelon. Medial ones are very rare. This is one of the few examples I have of a medial retropharyngeal node, very rare. Internal jugular, they're usually around the vein, but also they're frequently away from the vein. So this is 2B. And once they're involved here, they can then go down the neck, both in the posterior triangle and the internal jugular chain. If you see nodes posterior to the vein, always think about the nasopharynx, because it's not such a common site for nodes that are in the rest of the pharynx. And in the submandibular region, as I said, they're quite rare. Usually you may get them when there's bulky nodes elsewhere. But they are important to pick them up in the submandibular and parotid, because now with IMRT, the RT radiotherapists try to spare those areas. So if you see nodes, obviously they can't spare it. And one of the problems is with IMRT, we are now finding that nodes are coming back more frequently in the parotid region than they did before. So look very carefully for intraparotid and periparotid nodes. The other problem that we've had is that we're now aware of the superior sympathetic ganglia. They're usually bilateral, usually at C2, and they are vertically orientated. They tend to have a higher signal and more enhancement than nodes, and they, on the whole, although they can be large, most are actually less than 5 millimeters in minimum dimension. So they don't usually cause us a problem calling them metastatic nodes. The other clue is they often have this little dark spot in them, which is considered to be little venules or interlacing neurites. So these are the superior sympathetic ganglia. When you stage, unilateral disease is N1, and this is different to SCC. But if you've got bilateral retropharyngeal, that's still N1. N2 disease is bilateral disease. And N3 is a node that's more than 6 centimeters. And in the latest one, we don't have supraclavicular fossa anymore. It's any nodes that are distal to the lower margin of the cricoid cartilage is N3, which makes it a lot easier when we come to staging. So what are the key points for nodal metastases? Well, once it's bilateral, again, an indication to add chemotherapy. RT planning, look for nodes around the submandibular glands and also the lower extent. And N3, that's a node more than 6 centimeters or below the cricoid, is a marker for distant mets. And where we are, we can't do PET scanning everybody. So we use this as a marker to then go on for PET scanning to look at the whole body. If you're measuring it, you can measure the whole distance, even the matted nodes together. And in fact, we found that nodal volume, the volume of nodes, is a very good predictor for distant metastases. So really, I've just got 10 minutes just to go over, and I just want to talk about the new area, the area where we're using MRI. So in the past, patients already had proven NPC, biopsy proven, and then we would stage it. But we became aware many years ago that actually we could usually see nearly all the tumours. It was very rare they ever sent a tumour to us that we couldn't find. So then we realized actually we can use MRI to detect the tumour as well. And why should we want to do that? Well, at the moment, the way that we make the diagnosis is endoscopy and biopsy. Now, when the endoscopists look in, usually they can see an NPC. It's not difficult. But sometimes patients have got lymphoid hyperplasia, even adults. Again, that's usually not difficult, but sometimes it is. But the greater worry is when the endoscopist looks in and he sees nothing. And that is because the tumours can be hidden. They can be hidden in the pharyngeal recess, and they can be submucosal. And then they can miss the tumour. Now, in the past, we used to do sampling biopsies to try and detect it. But even that only detects a small area. So that's where MRI has come in. So if we go back, we looked at the anatomy. Remember, this is the eustachian tube. This is the levator palatini and the torus tubarius. And at the back here is the pharyngeal recess. And this is a common site for NPC to start. And this is the site where sometimes the endoscopists can't see in. Now, this one would be easy because it's wide open, but often it's closed and it's difficult to see the whole of that fossa. This is a case of an early NPC here. Now, you imagine the endoscopist is looking in and all they can see is this. It's very difficult to see this tumour here. We looked at this several years ago. We did a prospective study comparing MRI and endoscopy and endoscopic biopsy, either targeted or random. And then we did a 3-year follow-up, and that was in about 237 patients, of which 78 had NPC. Now, at that time, on MR, we picked up all the tumours. We were all blind to each other. We picked up all the tumours. We know that MR will miss some now. There are some very symmetrical tumours that can look very benign. Those are usually picked up on the endoscopy. So I think MR and endoscopy go together. But overall, MRI, very high sensitivity. The specificity is slightly lower because sometimes you've got benign change that's a bit asymmetrical. When we use that as our criteria for NPC, it had a very low specificity. But when we see small masses like the one I showed, they were always cancer. And in this study, for the follow-up, 12% of these tumours could not be seen endoscopically. They could only be seen on MR. And MRI could detect tumours up to 3 years before they were visible on the endoscope. And this is an example. This patient came along in 2007. We can see a very small tumour here. We called it a tumour. We staged it. The endoscopy was normal. Biopsy was normal. After this study, because we'd found it, they went back and they biopsied the site, and it was still difficult, still negative. But we said it's cancer. They came back in 2009. At that time, endoscopy still normal, and the patient had had enough. The biopsies are quite invasive, didn't want another one. And in 2010, they came back again, when you can see that now the tumour has increased in size. They could see it, and they biopsied it. So we can pick these up 3 years before. A lot of these tumours are slow growing. So 3 years before. We then went on, and we've just been involved recently in a population screening study, an EBV DNA screening study of 20,000 men in Hong Kong. Those with persistently raised EBV DNA, not just one, they had to have 3, went on and had endoscopy and MRI. They picked up 33 NPCs, and the important thing is that 71% were early stage. Historically, it's only 20%. So this could be a game changer. If we can pick these up early, all early cancers, we can actually change the face of NPC for the future. Now, we picked up 3 that couldn't be seen, so there were, which is 9%. But since the study closed and this was published, there's another one again that we picked up. It's taken them 3 years to prove it. So we've had another slowly growing one. So 12% in this are endoscopically occult, and there are at least 1 or 2 more. So we think it's going to be up to about 15% by the time we get the follow-up. So MRI really can pick up these early tumours. How does it help? Well, if you've got a normal endoscopy, but you're suspicious, you've got neck nodes, you've got cranial nerve palsies, persistently raised EBV DNA. If you do your MR and it's all symmetrical and you can see nothing and the endoscopy is negative, chances are there's no NPC. You don't need to do sampling biopsies. But, again, we may pick up these early ones. If you've had an abnormal endoscopy and the biopsy shows lymphoid hyperplasia, then it can be helpful. In this case, they could see a bulge, they biopsied it, but it was probably too superficial because there's the carotid artery. Once you show where it is, they know how deeply they can go and they can do navigation. And very often they see something that looks as if it might be cancer in the adenoid, but you can see the striped appearance. You've got the enhancing stripes and the low lymphoid columns. If you see this and it's symmetrical, it's probably going to be benign. So that's where MRI can help. So MRI positive, it guides the site of biopsy. If both are negative, you can avoid sampling biopsies. So this is just my last slide, conclusion, just to say, given you the background, looked at the staging, presented a structured report which you can go through, very useful for the trainees because it's got all the things to look at. You can then add to the structured report with free text. I've gone through some of the primary tumour staging with an emphasis on the skull base, mainly for the trainees. A little bit of how we nodal stage NPC and how we're now using it for early detection. Thank you.